Good morning. Welcome to the lecture on geriatric emergencies. At the completion of this chapter and all related coursework, you will understand the physiologic and psychological changes that occur with the aging process. You will also learn and understand the types of illness and injuries common to the geriatric population, and you will understand the GEMS triangle, use of advanced directives, and signs and symptoms of elder abuse. Regarding the National EMS Education Standard competencies for special patient populations, the EMT will apply the fundamental knowledge of growth, development, and aging and assessment findings to provide basic emergency care and transportation for a patient who has special needs. Regarding geriatrics, you will understand the impact of age-related changes on assessment and care, as well as changes associated with aging, psychosocial aspects of aging, and age-related assessment and treatment modifications for the major or common geriatric diseases and/or emergencies, including cardiovascular disease, respiratory disease, neurologic disease, endocrine diseases, Alzheimer's, and dementia. You will also recognize and report abuse and neglect and understand the healthcare implications of abuse and neglect in the geriatric population, as well as regarding trauma. You will apply fundamental knowledge to provide basic emergency care and transportation based on your assessment findings for an acutely injured patient. Specifically regarding the pathophysiology, assessment, and management of trauma in the geriatric population. Geriatrics is the assessment and treatment of diseases in a person who is 65 years old or older. The baby boomer generation, which are people born between 1940 and 1960, are more active and fit than people their age were in previous generations. 65 years is used as the threshold age to be consistent with the definition used by other medical groups and governmental agencies for the geriatric population. Realistically, though, we have to realize that how fast a person ages is a function of genetics, lifestyle, and attitude. The process of aging is gradual and starts much earlier than most people realize. Your systems of the human body start to decline as early as the late 20s, and that progresses slowly throughout life. The older population is growing to a larger percentage of the overall population, which gives us more people in the geriatrics group. Geriatric patients present as a special problem for caregivers because the classic presentation of disease is oftentimes altered by the presence of chronic conditions and the physiology of aging. As the elderly population increases, communities, companies, and hospitals are encouraging awareness of geriatric issues. It is important to understand and appreciate how the life of an elderly person might differ from yours. It takes time and patience to interact with an elderly person, and this can sometimes be frustrating. You must have patience and treat your patients with respect. You should make every attempt to avoid ageism. Ageism is the stereotyping of elderly people, and that often can lead to discrimination. You must realize that not all older people have dementia, not all older people are hard of hearing, and not all older people are sedentary or immobile. Elderly people can stay fit and be active even though they are not able to perform at the same level they did when they were in their youth. Good verbal communication skills are essential to a successful assessment and treatment in the older population. The aging process brings with it changes in vision, hearing, taste, smell, and touch. There are changes in communication abilities that accompany aging, dementia, and other diseases. Your first words to the patient and the attitude behind them can gain or lose a patient's trust. You should speak respectfully when you introduce yourself, and you should use your patient's proper name, Mr. Jones, Mrs. Smith. Address the patient by using sir, ma'am, Mr., Mrs., or Ms. Never use familiar or casual terms when referring to your patients unless they have told you to do so. Some terms I've heard quite frequently are hun and bud or sweetie. These are not to be used when we're taking care of patients. When you are interviewing an older patient, the following techniques should be used. First, identify yourself. Avoid showing frustration and impatience through your body language. You look directly at the patient at eye level and you ensure that there is good lighting. And you speak slowly and distinctly. Have only one person talk to the patient and only ask one question at a time. You should never assume that all people who are older are hard of hearing. Give the patient time to respond and listen to their answers. Explain what you will do before you do it, and do not talk about the patient in front of them as though they are not present. The changing physiology of geriatric patients can predispose this population to a host of problems not seen in youth. For example, a simple rib fracture in an 80 or 90-year-old can result in pneumonia and even a deadly secondary lung infection. A hip fracture from a low-mechanism fall is common in elderly people and may have dire consequences. Hip fractures are more likely to occur when bones are weakened by osteoporosis or infection, and sedentary behavior while healing can predispose the patient to pneumonia as well as blood clots. The most frequently occurring conditions in older persons are hypertension, respiratory diseases, diagnosed arthritis, and heart disease. The leading causes of death in the geriatric populations include heart disease, cancer, stroke, chronic obstructive pulmonary disease, and other respiratory illnesses, diabetes, and trauma. Assessment of an elderly person can be challenging because of communications issues, hearing and vision deficits, alteration in consciousness, complicated medical histories, and the effects of medications. When we perform an assessment on patients in this age group, we follow the same steps. We do a scene size up, we perform a primary assessment, we take a history, we perform our secondary assessment, and then we reassess. We always check the scene for any hazards. Geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facilities. You should remember that many older people today are able to live alone, and access to them may be hampered in cases in which the patients have conditions that prevent them from getting to the door. Sometimes we may need to request the assistance of the police or the fire department. Many older people try to maintain their independence as long as they can, and you need to take note of any negative or unsafe environmental conditions. You should look for clues that might explain the patient's medical history or current problem. In a nursing home or residential care facility, you will need to locate the patient's room and find a staff member who can explain why you were called. In any case in which the patient's mental status is altered, you need to find someone who can tell you the patient's history and whether the patient's behavior or level of consciousness is normal for their conditions. The nature of illness may be difficult to determine in older people who may have an altered mental status or dementia. You must ask the family member, caregiver, or bystander why they called. Multiple and chronic disease processes may also complicate the determination of the nature of the illness. Complaints from an elderly person may be vague, and chest pain, shortness of breath, or an altered level of consciousness should always be considered serious. For our primary assessment, you should address the life threats and determine the priority of your patient based on their condition. Form your general impression, and as you approach the patient, you should be able to tell if the patient is generally in stable or unstable condition. Use the AVPU scale to determine the patient's level of consciousness. Evaluate airway and breathing. Remember, anatomic changes that occur as a person ages predispose the geriatric patients to airway problems. Aging and disease can compromise a patient's ability to protect his or her airway with loss of a gag reflex and normal swallowing mechanisms. Changes in the level of consciousness, dementia, and post-stroke weakness or paralysis can cause airway obstruction or aspiration. Ensure that the patient's airway is open and not obstructed by dentures, vomitus, fluid, or blood. Remember, suction may be necessary. Anatomic changes also affect a person's ability to breathe effectively, and these include things like increased chest wall stiffness, brittle bones, weakening of the airway musculature, decreasing muscle mass. Loss of mechanisms to protect the upper airway, such as cough and gag reflexes, can cause a decreased ability to clear secretions. A decrease in the number of cilia that line the bronchial tree results in the inability of the patient to remove material from the lung, which can cause infection. In some patients, the alveoli are damaged, and a lack of elasticity results in a decreased ability to exchange oxygen and carbon dioxide. Airway and breathing issues should be treated with oxygen as soon as possible. Evaluate circulation. Poor perfusion is a serious issue in the older adult. Physiologic changes may negatively affect circulation, and some of these include a less responsive nerve stimulation that may lower the rate and strength of the heart's contractions. You may also see lower heart rates and weaker and irregular pulses, and these are very common in elderly patients. Vascular changes and circulatory compromise might make it difficult to feel a radial pulse on an older patient, and circulation problems in older adults should be treated with oxygen as soon as possible. Make your transport decision. Patient assessment is more complicated in an elderly adult, and multiple problems can exist. Any complaints that compromise airway, breathing, or circulation should result in transportation of the patient as a priority. Your most important task is to determine conditions that are life-threatening, treat them to the best of your ability, and provide transport to priority patients. A priority patient includes patients who have a poor general impression, any airway or breathing problems, an acute altered mental status, shock, severe pain, and uncontrolled bleeding. Elderly people do not have the reserves that younger people do, and they easily decompensate. You should consider early on if ALS treatment and immediate transport is appropriate and available. Take a history. When taking a history, we need to investigate the chief complaint. You should find and account for all medications. Communication may be more complicated with an older adult, but it is critical that you obtain a thorough patient history. The determination should be made early on as to whether the altered level of consciousness is acute or chronic. Chronic mental status impairment is not a normal process of aging, but is caused by a pathologic or disease process. The elderly may not show severe symptoms even if they are very ill. You must determine your patient's baseline mental status. Multiple disease processes and multiple and/or vague complaints can make assessment complicated. Ask questions to assess the nature of the problem and determine whether it may or may not be life-threatening. Take a full set of vital signs and use the acronym OPQ-RST for chest pain and PASTE, P-A-S-T-E, for shortness of breath. Collect a sample history. You may have to rely on a relative or caregiver to help you in collecting a sample history. Note the signs you observe and your general impression. Make sure you have a list of the patient's medications or take the medications with you to the hospital. The last meal is particularly important in a patient with diabetes, but negative nutrition can have a negative effect on a patient. It is advantageous to provide transport to a facility that knows the patient's medical history. The secondary assessment may be useful and may be performed on scene en route to the emergency department or not at all. When you do your physical exam, you must remember that your elderly patient may not be comfortable with being exposed, and you should protect their modesty. And consider the need to keep your patient warm during your full body scan. Take vital signs. The heart rate should be in the normal adult range, but may be compromised by medications such as beta blockers. It is common in elderly patients that they may have weak and irregular pulses. Circulatory compromise may make it difficult to feel a radial pulse on an older patient, and other pulse points may need to be considered. Blood pressure tends to be higher in the elderly population. Capillary refill is not a good assessment because of skin changes and reduced circulation to skin. The respiratory rate should be in the same range as in a younger adult, but remember that chest rise will be compromised by increased chest wall stiffness. Be sure to auscultate breath sounds and to listen for rales, which can be associated with pulmonary edema, rhonchi or rattles associated with pneumonia, and wheezes associated with asthma. Careful interpretation of pulse oximetry data is necessary in older adults because the pulse oximetry device requires adequate perfusion to get an accurate reading. It may be helpful to use adhesive temporal probes with the pulse oximetry, as this might help confirm data accuracy. A blood pressure of 120 over 80 millimeters of mercury could be an indication of a significant problem in an elderly patient. Then you should reassess. You'll repeat your primary assessment, reassess the vital signs, reassess the patient's complaint, recheck all of your interventions, and identify and treat any changes in the patient's condition. Typically, your interventions include positioning, oxygenation, administration of glucose, and psychological support. In specific cases, you may also assist with nitroglycerin, aspirin, or inhalers. Allow the patient to maintain a position of comfort unless he or she is unable to maintain it. Provide oxygenation and ventilation as needed. Remember, oxygen is a useful therapy for many in the geriatric population, and be mindful of monitoring level of consciousness in a patient with COPD. Consider glucose therapy for patients with diabetes who have altered mental status but has a manageable airway. You should also consider assisting with the patient's nitroglycerin if they are having chest pain, or assist with medication for asthma when they have shortness of breath. Listen to your patient, respond to your patient, and provide reassurance. Communicate with the hospital staff on your findings and the interventions you use to improve the patient's condition. Document all history, medication, assessment, and intervention information. Table 33.2 has some geriatric patient assessment guidelines, and these are useful for study guide. The GEMS Diamond. The GEMS Diamond was created to help you remember what is different about older patients. It is not intended to be a format for the approach to geriatric patients, nor is it intended to replace the ABCs of care. Instead, it serves as an acronym for the issues to be considered when assessing every older patient. G stands for geriatric patient. Consider that older patients are different from younger patients and may present atypically. E stands for an environmental assessment. Assessing the environment can help give you clues to the patient's condition and the cause of the situation or the emergency. Preventative care is very important for a geriatric patient who may not carefully study the environment or may not realize where risks exist. M stands for medical assessment. Older patients tend to have a variety of medical problems and may be taking numerous prescription, over-the-counter, and herbal meds. You should obtain a thorough medical history as it is very important. S stands for social assessment. Older people may have less of a social network because of the death of a spouse, family members, and friends. They may also need assistance with activities of daily living. And you should consider obtaining information pamphlets about some of the agencies for older people in your area. So this slide has a great synopsis of what the GEMS Diamond stands for and the things we need to look for, and again, makes a great study guide. Human growth and development peaks in the late 20s and early 30s, at which point the aging process sets in. Remember, aging is a linear process, and the process can vary dramatically from one person to another. The aging process is inevitably accompanied by changes in physiologic function, such as a decline in the function of the liver and kidneys. All tissues in the body undergo aging. The decrease in the functional capacity of various organ systems is normal, but can affect the way in which a patient responds to illness. Health professionals need to make sure they are knowledgeable about this decreased function because it will enable you to correctly respond to the patient's illness. Do not mistake the changes for signs of illness and be tempted to give treatment when none is necessary. At the other end of the spectrum, do not attribute genuine disease symptoms to just getting old and neglect treatment. Older adults can be predisposed to respiratory illnesses. One of the conditions contributing to breathing problems is weakening of the airway musculature, and that causes decreased breathing capacity. Elderly patients have less help from muscles in the chest wall when they have trouble breathing. The alveoli in an older person's lung tissue can become enlarged, and the elasticity decreases, and that makes it harder to expel used air. The body's chemoreceptors, which monitor the changes in oxygen and carbon dioxide levels in the blood, slow with age. Pneumonia. COPD, influenza, and pneumonia are the top 5 causes of geriatric deaths. Pneumonia is an infection of the lungs from bacterial, viral, or fungal causes. It is the leading cause of death from infection in Americans over the age of 65, and you should remember to wear respiratory protection when you're assessing a patient who may have a potentially infectious respiratory disease. Some factors that predispose a patient to pneumonia are whether the patient is institutionalized or not, if they have any chronic disease processes, if they have a compromise of their immune system, if they have a history of COPD or cancer, or if they have a history of inhaled toxins or aspiration of material into the lung. The patient with pneumonia may present with cyanosis and pallor, dry skin, possible fever, increased skin turgor, pale dry skin mucosa, a furrowing tongue, tachycardia, hypotension, diminished breath sounds with wheezing, rales, or rhonchi. The patient should be treated with airway, ventilatory, and circulatory support. Pulmonary embolism. PE is a condition that causes a sudden blockage of an artery by a venous clot. A patient with a PE will generally complain of symptoms of chest pain. Thus, it can obviously be confused with a cardiac, lung, or musculoskeletal problem. Risk factors for PE include recent surgery, history of blood clots, obesity, recent long-distance travel, sedentary behavior, or other conditions that render the patient bedridden. For pulmonary embolism, patients may present with tachycardia, sudden onset of dyspnea, shoulder, back, or chest pain, cough, syncope in a patient who has a clot that's larger, as well as anxiety. Other signs and symptoms include apprehension, potentially a low-grade fever, leg pain, redness, and unilateral pedal edema, fatigue, and in a worst-case scenario, cardiac arrest. Assessment of vital signs will reveal changes in circulation because the patient may have an unusually rapid and possibly irregular heartbeat and possible hypotension. Wheezing, growls, or decreased breath sounds may be heard. Patients with pulmonary embolism may present with a pulse oximetry reading of 70% or lower. Treatment should focus on airway, ventilatory, and circulatory support. Any blood that is coughed up should be cleared from the airway, and supplemental oxygen is mandatory. Cardiovascular system changes. A variety of changes occur in the cardiovascular system as a person ages, with the net effect of a decrease in the efficiency of the system. The heart hypertrophies with age, probably in response to the chronically increased afterload imposed by stiffened blood vessels. Over time, cardiac output declines, mostly as a result of a decreasing stroke volume. Arteriosclerosis contributes to a systolic hypertension, which places an extra burden on the heart. Some changes in cardiovascular performance are probably not a direct consequence of aging, but rather reflect the deconditioning effect of a sedentary lifestyle. As we age, many people tend to limit physical activity and exercise. With aging, a person's ability to speed up contractions, increase contraction strength, and constrict or narrow blood vessels is decreased because the vessels are now stiffer. The heart may also lose its ability to raise cardiac output to meet the body's needs. Geriatric patients are at risk for atherosclerosis and accumulation of fatty material in the arteries. It is one of the biggest concerns in this population, and one of the major complications of this includes myocardial infarction and stroke. It affects more than 60% of the people aged 65 or older, and atherosclerosis makes stroke, heart disease, hypertension, and bowel infarction more likely. You see here pictures of a normal arterial wall, the normal musculature, lumen, and lining. In the bottom, you see a buildup of cholesterol, calcium, which narrows the lumen. It causes blood clots, as you can see, and this decreases the effectiveness of the flow of blood through the arteries and veins. Older people are also at an increased risk for aneurysm, an abnormal blood-filled dilation of the wall of a blood vessel. Severe blood loss can occur when an aneurysm bursts. The blood vessels themselves become stiff, which results in a higher systolic blood pressure. Some other anatomic changes include stiffening and degeneration of the valves, which may impede normal blood flow in and out of the heart. Aging also alters the heart's electrical conduction system, and this can cause a heart rate that is too fast, too slow, or too erratic to provide effective blood flow in the body. Orthostatic hypotension is a drop in blood pressure with a change in position. The body is less able to compensate for rapid postural changes. Another vessel-related problem is called venous stasis. This refers to the loss of proper function of the veins in the legs that would normally carry blood back to the heart. It causes blood clots in the superficial veins, which is called superficial phlebitis, and blood clots in the deep veins, which is called deep venous thrombosis, or DVT. People with this condition usually exhibit edema or swelling in the legs and ankles. Eventually, this causes a reddish-brown discoloration of the skin, and in some cases, skin ulcers. Heart attack, or myocardial infarction. The classic signs of a heart attack are often not present in the geriatric population. Silent heart attacks are particularly common in women and people with diabetes. Treatment of the following associated symptoms as seriously as if the patient has chest pain: dyspnea, epigastric and abdominal pain, nausea and vomiting, weakness, lightheadedness and syncope, fatigue, and confusion. Table 33.3 in one synopsis gives you common signs and symptoms of MI in geriatric patients, and as always is a useful study guide. Other signs and symptoms that can indicate a cardiovascular problem include issues with circulation, diaphoresis, pale cyanotic mottled skin, adventitious or decreased breath sounds, and increased peripheral edema. You should obtain as much information as possible from the patient and get baseline vitals. This information will provide you with a primary picture of the severity of your patient's condition, and you can use these findings to measure against in your ongoing assessment of the patient. Treatment mostly consists of airway, ventilatory, and circulatory support, and cardiac problems can be expected to worsen suddenly, so be prepared. Heart failure. The signs and symptoms will differ depending on the extent to which the right and or left side of the heart is not functioning correctly. The heart is not able to maintain cardiac output that meets the needs of the body. Risk factors include hypertension, a history of coronary artery disease, and atrial fibrillation. In left-sided heart failure, fluid backs up into the lungs. This causes a condition called pulmonary edema and shortness of breath. Right-sided heart failure occurs when fluid backs up in the body. You will see jugular vein distension and fluid in the abdomen. You may also see signs of an enlarged liver, which is determined by palpation. Associated signs and symptoms include dyspnea on exertion, paroxysmal nocturnal dyspnea. This is a condition which is characterized by a sudden attack of respiratory distress that wakes the person at night when he or she is reclining. Tachypnea, accessory muscle use, anxiousness, and fatigue. Other associated signs and symptoms include associated chest pain, diaphoretic and cyanotic skin, crackles, wheezing, or rouse, tachycardia, hypertension. Treatment always consists of airway, ventilatory, and circulatory support. Stroke. Stroke is a leading cause of death in the elderly, and preventable risk factors include smoking, obesity, and a sedentary lifestyle. Less preventable causes are high cholesterol and hypertension, and uncontrollable factors include cardiac disease and atrial fibrillation. Signs and symptoms of a stroke include altered mental status, numbness, weakness, or paralysis on one side of the body, slurred speech, difficulty speaking or aphasia, and visual disturbances, as well as headache and dizziness, incontinence, and seizures. Ischemic strokes occur when a blood clot blocks the flow of blood to a portion of the brain. Hemorrhagic strokes, in which a broken blood vessel causes bleeding into the brain, are less common and more likely to be fatal. The treatment goal for ischemic strokes is to salvage as much of the surrounding brain tissue as possible, and determining the onset of the symptoms is vital. Nervous system changes. Changes in thinking speed, memory, and posture stability are the most common normal findings in older people. The brain decreases in terms of weight by 10 to 20% in volume as a person ages. This increases the amount of space in the cranium, thus increasing the chance for head injury. Head injury with a minimal mechanism are commonly missed in the elderly population. In the older population, there is a 5 to 50% loss of neurons. Remember, neurons are responsible for transmission of impulses, so the motor and sensory neural networks slow down with age. This affects the control of the rate and depth of breathing, heart rate, blood pressure, hunger, thirst, and body temperature. The performance of most of the sense organs declines with increasing age as well. Visual acuity, depth perception, and the ability of the eyes to accommodate to light change with age. Cataracts, which are clouding of the lenses or their surrounding membranes, interfere with vision and make it difficult to distinguish colors and see clearly. Decreased tear production will lead to drier eyes. Older people develop an inability to differentiate colors and have decreased night vision. The inability to see up close is called presbyopia, and it is caused by a loss of elasticity of the crystalline lens. A number of other disease processes plague the vision of older adults, including glaucoma, macular degeneration, and retinal detachment. Typical hearing problems cause changes in the inner ear and make hearing high-frequency sounds difficult. Changes in the ear can also cause problems with balance and make falls more likely. Presbycusis is a gradual hearing loss that occurs as we age. Hereditary and long-term exposure to loud noises are the main factors that contribute to hearing loss. When assessing your patient, you should check for the use of hearing aids. The sense of taste can be diminished because of a decrease in the number of taste buds. The negative result might be lessened interest in eating, which can lead to weight loss, malnutrition, and fatigue complaints. An older person may have a decreased sense of touch and pain perception from the loss of the end nerve fibers. This loss can create situations in which an older person may be injured and not know it, and this is specific because there is a decreased sensation of heat and cold. Dementia is the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. It is a chronologic, generally irreversible condition that causes a progressive loss of cognitive abilities, psychomotor skills, and social skills. Dementia is the result of many neurologic diseases and may be caused by Alzheimer's, cerebrovascular accidents or strokes, and genetic factors. You make an evaluation of pathophysiology through history, risk factors, and current medications. On assessment, the patient might exhibit loss of cognitive function. Patients may have short and long-term memory problems and a decreased attention span, or they may be unable to perform their daily routines. They also may show a decreased ability to communicate and appear confused. Other aspects of dementia can complicate your ability to assess and manage the patient. Sometimes patients are not only confused, but angry as well. They will have impaired judgment, and they may be unable to vocalize areas of pain and current symptoms. They also may be unable to follow commands. Patients with dementia may express anxiety over movement out of their current residence, and you must exercise extreme tolerance and patience with these patients. Delirium is a sudden change in mental status, consciousness, or cognitive processes. It is marked by the inability to focus, think logically, and maintain attention. Delirium affects 15 to 50% of hospitalized people who are 70 or older. Acute anxiety may be present in addition to the other symptoms, but usually their memory remains intact. This condition is generally the result of a reversible physical ailment such as tumors or fever or a metabolic cause. Other important things to look for in the history are intoxication or withdrawals from alcohol, sedative withdrawal, and medical conditions such as UTIs, bowel obstructions, dehydration, fever, cardiovascular disease, and hyper or hypoglycemia. Other conditions that you may need to look for in the history include psychiatric disorders such as depression, malnutrition and vitamin deficiencies, and environmental emergencies. You should assess and manage the patient for hypoxia, hypovolemia, and hypoglycemia. Geriatric patients will respond to oxygen for hypoxia, placement in the shock position, and ALS support with IV fluids for hypovolemia and intravenous glucose given for hypoglycemia. Indications include changes in circulation, response of the pupils, and response to motor tests, adventitious breath sounds, low blood pressure, which can indicate hypovolemia, dilated pupils can suggest hypoxia, look for wheezing, rouse, and rhonchi. Remember, treatment should include airway ventilatory and circulatory support and oxygen with airway adjuncts. Syncope or fainting. Always assume that this is a life-threatening problem until proven otherwise. It is often caused by an interruption of blood flow to the brain, and an older person who has a period of unconsciousness should be examined to determine the cause of their syncope. Neuropathy. Neuropathy is a disorder of the nerves of the peripheral nervous system in which function and structure of the peripheral motor, sensory, and autonomic neurons are impaired. Symptoms depend on whether the nerves affected are motor, sensory, or autonomic, and where the nerves are located. Motor nerves, you may see muscle weakness, cramps, and spasms, as well as loss of balance and coordination. With sensory nerves, there may be tingling and numbness, itching, pain, burning, freezing, or extreme sensitivity to touch. With the autonomic nerves, you may see changes in blood pressure and heart rate, as well as constipation and bladder and sexual dysfunction. Changes in the GI system. Changes in the mouth include a reduction in the volume of saliva with a resulting dryness of the mouth. Dental loss is widespread in the elderly population and contributes to nutritional and digestive problems. Like oral secretions, gastric secretions are reduced as a person ages. Enough acid is still present to produce ulcers under certain conditions. Changes in gastric motility also occur, which may lead to slower gastric emptying. Function of the small and large bowel changes little as a consequence of aging. The incidence of certain diseases involving the bowel increases as a person grows older. Nutrients from food are not as readily absorbed, and blood flow to the liver declines. The activity of the enzyme systems involved with the detoxification of drugs declines as a person ages. Age-related changes to the gastrointestinal system include issues with dental problems, decrease in saliva and sense of taste leading to poor nutrition, poor muscle tone of the smooth muscle sphincter between the esophagus and stomach, and this can cause regurgitation and lead to heartburn and acid reflux, a decrease in hydrochloric acid in the stomach, alterations in absorption of nutrients and slowing peristalsis, and weakening of the rectal sphincter. Changes in the liver predispose elderly patients to a number of problems, including realization that the liver, which is responsible for removing toxins and breaking down drugs in the body, shrinks with age. Blood flow to the liver also declines, and there is decreased metabolism. This will have a direct effect on how medications may affect your patient. Serious GI issues that affect elderly people include GI bleeding. Bleeding that travels through the lower digestive tract usually manifests as melena, which is black tarry stools. Red blood usually means a local source of bleeding, such as hemorrhoids. A patient with GI bleeding may experience weakness, dizziness, or syncope. Bleeding in the GI system can be life-threatening. They may also have inflammation, infection, or obstruction of the upper and lower GI tract. Specific GI problems that are more common in older patients include diverticulitis. This is a condition in which small pouches protrude from the colon, and generally the geriatric patient will present with left lower quadrant pain and fever. Bleeding in the upper and lower GI system. Upper GI bleeding occurs in the esophagus, stomach, or duodenum. Irritation of the lining of the stomach or ulcers can cause forceful vomiting that tears the esophagus. Hepatitis and cancer can also contribute to bleeding problems. Peptic ulcer disease. This is more common in older adults, especially those who use NSAIDs. The patient will complain of a gnawing, burning pain in the upper abdomen that improves after eating but returns later. Complications include bleeding, anemia, and bowel perforation. Gallbladder disease. This is more common in older adults, and they have a higher risk of complications from gallstones. Patients will complain of sharp right upper quadrant pain, and the pain may radiate to the back and right shoulder. Patients will present with inflammation of the gallbladder called cholecystitis and jaundice. Bowel obstruction. The ability of the GI tract to move feces through the system slows with aging, and patients can experience problems having bowel movements. When patients are straining to have a bowel movement, they can stimulate the vagus nerve and produce a reaction called a vasovagal attack. This is a condition in which the heart rate drops dramatically and the patient becomes dizzy or passes out. In general, patients with GI issues will present with hematemesis, which is bloody vomitus, melena, which is dark tarry stools, dyspepsia, indigestion, hepatomegaly, an enlarged liver, constipation, and diarrhea. When assessing patients, ask about the use of alcohol and NSAIDs, non-steroidal anti-inflammatory drugs. Presentation can include pale or yellow thin skin, frail musculoskeletal system, peripheral sacral and periorbital edema, hypertension, fever, tachycardia, and dyspnea. Orthostatic vital signs can determine if a patient is bleeding internally. Blood pressures and pulses are obtained with the patient lying down, sitting, and standing. Auscultation of breath sounds should be performed to detect adventitious noises or possible foreign bodies. Treatment consists of airway, ventilatory, and circulatory support. The acute abdomen, non-GI complaints. Abdominal complaints in geriatric patients are extremely difficult to assess. In the field, the most serious threat from abdominal complaints is blood loss, which can lead to shock and death. An abdominal aortic aneurysm, or AAA, is one of the most rapidly fatal conditions. It tends to develop in people who have a history of hypertension and atherosclerosis. The walls of the aorta weaken and blood begins to leak into the layers of the vessel, causing the aorta to bulge like a bubble on a tire. If enough blood is lost into the vessel wall itself, shock occurs. If the vessel wall bursts, it rapidly leads to fatal blood loss. A patient with a AAA most commonly reports abdominal pain radiating through to the back and occasional flank pain. If you see or palpate a pulsating mass, do not continue manipulation or allow other providers to palpate the mass. Treat the patient for shock and provide prompt transport to the hospital. Renal system changes. The largest component of the urinary system is the kidneys, or the renal organs. Age-related changes in the genitourinary system to the kidney include reduction in renal function, reduction in renal blood flow, and tubal generation. For the genitourinary system in general, there is a decrease in bladder capacity, a decline in sphincter muscle control, a decline in the voiding senses, and an increase in nocturnal voiding. There's also an enlarged prostate or benign prostatic hypertrophy in men. The kidneys are responsible for maintaining the body's fluid and electrolyte balance and have important roles in maintaining the body's long-term acid-base balance and eliminating drugs from the body. The kidneys decline in weight as a person ages, and renal blood flow decreases by as much as 50%. Acute illness in elderly patients is often accompanied by derangements in fluid and electrolyte balance. Bowel and bladder continence require autonomically correct GI and genitourinary tracts. functioning and intact sphincters, and properly working cognitive and physical functions. Incontinence is not a normal part of aging and can lead to skin irritation, skin breakdown, and urinary tract infections. An increase in nocturnal voiding is common, and there are two major types of incontinence that are distinguished: stress and urge. Stress incontinence occurs during activities such as coughing, laughing, sneezing, lifting, and exercise. Urge incontinence, on the other hand, is triggered by hot or cold fluids, running water, and even thinking about going to the bathroom. Treatment consists of medications, physical therapy, and possibly surgery. The opposite of incontinence is urinary retention or difficulty urinating. In men, enlargement of the prostate can place pressure on the urethra, making voiding difficult, as well as bladder and urinary tract infections that can cause inflammation. Endocrine system changes. The endocrine system functions as the control center of the body. A significant change that occurs in the elderly person is decreased metabolism of thyroxine. There is also decreased conversion of thyroxine to triiodothyronone. This is a reduction in these hormones, and it can cause a condition called hypothyroidism. Most of the signs and symptoms people experience are attributed to the process of aging and include a slower heart rate, fatigue, drier skin and hair, cold intolerance, and weight gain. Other endocrine changes include an increase in the secretion of ADH, also known as antidiuretic hormone, which causes fluid imbalances, increase in the levels of norepinephrine, possibly having a harmful effect on the cardiovascular system, and a reduction in pancreatic beta cell secretion, causing hyperglycemia. Hyperosmolar hyperglycemic nonketotic coma, or HHNC, is a type 2 diabetic complication in the elderly. The signs and symptoms of DKA and HHNC will often overlap. On assessment, you may see hyperglycemia, polydipsia or thirst, polyuria or urination, and polyphagia or hunger, as well as you may see dizziness, confusion, altered mental status, and seizures. On assessment, you may see changes in circulation, such as warm flushed skin, poor skin turgor, pale dry oral mucosa, and a furrowed tongue. The patient may present with signs and symptoms of hypotension and shock, including tachycardia. The blood glucose level will be greater than 500 milligrams per deciliter of blood in DKA, whereas in HHNC the value is generally greater than 300. DKA presents with Kussmaul's respirations and HHNC does not. Patient assessment should include getting a blood pressure, checking distal pulses, auscultation of breath sounds to detect adventitious noises, and determination of temperature. Treatment always includes airway, ventilatory, and circulatory support. Immune system changes. Infections are commonly seen in elderly people because they generally have an increased risk of infection and are less able to fight infections once they occur. Pneumonia and UTIs are common in patients who are bedridden. When infection occurs, signs and symptoms may be decreased and minimized in the patient because of a loss of sensation or a lack of awareness. They may also have a fear of being hospitalized. Changes in the musculoskeletal system. Aging brings a wide variety of changes to the musculoskeletal system, and it includes a widespread decrease in bone mass in men and women, but especially amongst postmenopausal women. Bones become more brittle and tend to break more easily, and the discs between the vertebrae of the spine begin to narrow, and a decrease in height of between 2 to 3 inches may occur through the lifespan, along with changes in posture. Joints lose their flexibility and may be further immobilized by arthritis, and a decrease in the amount of muscle mass often results in less strength. Changes in physical abilities can affect an older person's confidence in their mobility. Muscle fibers become smaller and fewer, motor neurons decline in number, and strength declines. Ligaments and cartilage of the joints lose their elasticity, and cartilage goes through degenerative changes. The stooped posture of an older person comes from atrophy of the supporting structures of the body. 2 of every 3 older patients will show some degree of kyphosis. Osteoporosis, a condition that affects men and women, is characterized by a decrease in bone mass leading to reduction in bone strength and greater susceptibility to fracture. The extent of bone loss that a person undergoes is influenced by numerous factors, including genetics, smoking, level of activity, diet, alcohol consumption, hormones, and body weight. The most rapid loss of bone occurs in women during the years following menopause. Many postmenopausal women use hormone replacement therapy as a means to reduce the loss of bone. And calcium and vitamin D supplements are another treatment for this condition, and many other medications are available to improve bone strength. Osteoarthritis is a progressive disease of the joints that destroys cartilage, promotes the formation of bone spurs in joints, and leads to joint stiffness. This results from wear and tear, and in some cases from repetitive trauma to the joints. It affects 35 to 45% of the population older than 65 years. It affects several joints of the body, most commonly those in the hands, knees, hips, and spine. Patients complain of pain and stiffness that gets worse with exertion, and patients are typically treated with anti-inflammatory medications and physical therapy. Skin changes. Collagen is a protein that is the chief component of connective tissue and bones, and elastin is a protein that helps to make the skin pliable. Reproduction of these proteins slows as the body ages, and that brings on a thinner and less robust appearance in older people. The layer of fat under the skin also becomes thinner because of the redistribution of fluids and proteins. As the elasticity of the skin declines, bruising becomes more common because the skin can tear more easily. Exocrine or sweat glands do not respond as readily to heat because of atrophy. Another problem that affects the skin is pressure ulcers, sometimes referred to as bed sores or decubitus ulcers. The pressure from the weight of the body cuts off the blood flow to the area of skin, and with no blood flow in the skin, a sore develops. To help prevent these ulcers, take special care to pad voids in a patient who may be on a backboard for an extended period. You may see these ulcers in the following various stages of development. Stage 1, which is where there's a non-blanching redness with damage under the skin. Stage 2, a blister or ulcer that can affect the dermis and epidermis. Stage 3, an invasion of the fat layer through to the fascia. And Stage 4, invasion to muscle or bone. Decubitus ulcers can be painful and cause complications such as bleeding, sepsis, and bone inflammation called osteomyelitis. Toxicology. The elderly are more susceptible to toxicity because of a decreased kidney function and altered GI absorption and decreased vascular flow in the liver. The kidneys undergo structural and functional changes with age, and decreased liver function makes it harder for the liver to detoxify the blood and eliminate substances such as medications and alcohol. These metabolic issues can also make it difficult for physicians to find the appropriate dosage for new medications. Typical over-the-counter meds used by elderly patients include aspirin, antacids, cough syrups, and decongestants. Most people believe OTC medications cannot be dangerous. However, these medicines can have negative effects when mixed with each other or with herbal substances, alcohol, as well as prescription meds. Polypharmacy refers to the use of multiple prescription medications by one patient. Patients may not remember what medications one doctor prescribed or may not want to tell one doctor about seeing another. Negative effects can include overdosing and negative medication interaction. Both overdose and underdose can lead to serious problems. Medication noncompliance in older patients is also an issue, and many occur because of financial challenges, a motor inability to open caps, and an impaired cognitive vision and hearing ability. Depression is not part of normal aging. Rather, it is a medical disease that occurs in about 6% of the population over the age of 65. It is treatable with medication and therapy, and if it goes unrecognized or untreated, it is associated with a higher suicide rate in the elderly population than in any other age group. Risk factors include a history of depression, chronic disease, loss of function, independence, or the significant other. Most suicide victims have seen their primary care physician within the month before the event. Unlike younger people, geriatric patients typically do not make suicidal gestures or attempt to get help. The rate of completed suicide is disproportionately high in the geriatric population, and many geriatric patients see no other way out when they have a terminal illness or debilitating cardiac or neurologic condition. At highest risk are white men, 85 or older, who use firearms as their suicide method of choice. For most older people, the later years are ones of fulfillment and satisfaction with a lifetime of accomplishments. For some older adults, later life is characterized by physical pain, psychological distress, and doubts about the significance of life's accomplishments. For others, it may be characterized by financial concerns, loss of loved ones, dissatisfaction with their living conditions, or a seemingly unbearable disability. Depression is a common, often debilitating psychiatric disorder experienced by approximately 2 million older American adults. It's diagnosed 3 times more commonly in women than men, and extreme and persistent. It is extreme and persistent and can interfere significantly with the older adult's ability to function. The following conditions contribute to the onset of significant depression: substance abuse, isolation, prescription medication use, and chronic medical conditions. Treatment usually consists of psychological counseling, medications, or a combination of both. Older men have the highest suicide rate of any age group in the United States. Older persons who attempt suicide choose much more lethal means than younger victims and generally have diminished recuperative capacity to survive an attempt. Some common predisposing events and conditions include the death of a loved one, a physical illness, depression and hopelessness, alcohol abuse, alcohol dependence, and a loss of meaningful life roles. Geriatric patients and trauma. In general, the risk of serious injury or death is more common in elderly patients who experience trauma than in younger patients. These conditions create risk and complicate the assessment of the geriatric patient. Some of the things that we see that cause this are slower homeostatic compensatory mechanisms, limited physiologic reserves, and the normal effects of aging on the body, as well as pre-existing medical conditions. Physical findings in an older adult may be more subtle and more easily missed. The mechanisms that cause serious injury in the elderly population are usually much more minimal than in younger people. There is also the consideration that recuperation from trauma is longer and often less successful in older people. Many injuries in the elderly are under-triaged and under-treated. According to the National Highway Traffic Safety Administration in 2008, 183,000 older people were injured in traffic crashes. Factors that affect elderly people while driving include distraction or confusion, decreasing hearing and vision, equilibrium or balance disorders, decreased mobility and reaction times, impairment by medications, as well as conditions such as hypoglycemia. Because of changes in the body, elderly pedestrians are more likely to have life-threatening complications after being struck by a vehicle. Falls are some of the more common mechanisms of injury for the elderly population. Safety and environment factors are often responsible, including poor lighting, loose floor coverings, and lack of handrails. Physiologic factors include vision and balance issues, decreased visual acuity, and decreased strength. A critically important assessment process is to determine if the fall was mechanical or pathologic. Cardiac, neurologic, and metabolic issues can create weakness, dizziness, or near syncope and may result in the patient's fall. Elderly people are more likely to experience burns because of altered mental status, inattention, and a compromised neurologic status. Their risk of mortality from burns is increased when pre-existing medical conditions exist, the immune system is weakened, or fluid replacement is complicated by renal compromise. There is a higher mortality from penetrating trauma in the older population, especially in the case of gunshot wounds. Penetrating trauma can easily cause serious internal bleeding. Trauma in elderly people can also be caused by abuse, and you should be aware of the environment and conditions a patient lives in. Take note of soft tissue injuries that cannot be explained by the person's lifestyle or physical condition. Anatomic changes. Changes in pulmonary, cardiovascular, neurologic, and musculoskeletal systems make older patients more susceptible to trauma. The brain shrinks, leading to higher risks of cerebral bleeding following head trauma. Skeletal changes cause curvature of the upper spine that often requires additional padding during spinal immobilization. Loss of strength, sensory impairment, and medical illness also increase the risk of falls. A geriatric patient's overall physical condition may lessen the ability of the patient's body to compensate for the effects of even simple injuries. A geriatric patient's blood pressure drops sooner than in a young adult patient during a traumatic emergency. The patient assessment steps are always the same for trauma, even medical or any other case. We size up the scene, we do our primary, we take a history, we complete a secondary, and we reassess. Remember, ensure your own safety first. Take standard precautions and consider the number of patients. Be sure you determine the need for additional or specialized resources. Look for clues that indicate whether your patient's traumatic incident may have been preceded by a medical event. Bystander information may help determine if the patient had a loss of consciousness. Mechanism is important in establishing whether an injury is considered critical, and it affects treatment and transport considerations. Address life threats. Determine the transport priority of the patient and be conservative in your thinking. Form a general impression. As you approach the patient, you should be able to tell if he or she is generally stable or unstable. Determine neurologic status, as this may be difficult if you do not know the patient's baseline. You should try to get information about the baseline from someone familiar with the patient, if at all possible. Use the AVPU mnemonic to determine post-traumatic status. An important consideration with any patient is the inability to remember the event. Evaluate airway and breathing. If the patient is talking to you, their airway is patent. Patients who have noisy respirations have an airway compromise. Older patients may have a diminished ability to cough, so suctioning is important. Assess for the presence of dentures, but do not remove them unless they are creating an airway patency problem. In the unresponsive patient, open the airway with a modified jaw thrust maneuver and perform a thorough respiratory assessment and physical assessment of the chest and treat accordingly. Use pulse oximetry to monitor oxygenation. Evaluate circulation. Manage any external bleeding immediately, and remember that older patients can more easily go into shock. A head injury with minimal mechanism can cause cerebral bleeding. Many elderly people take blood-thinning medications that can make internal bleeding worse or external bleeding more difficult to control. Patients who were hypertensive prior to injury may have a normal blood pressure when they are actually in shock. Make your transport decision. Remember, the physiologic changes secondary to aging can worsen the effects of trauma, and that older people do not heal from trauma as easily as do younger adults. Consider trauma center transport for geriatric patients if there is a potential for serious injury. Investigate your chief complaint. Considerations in your assessment of the patient's condition and stability must include past medical history, even if they are not currently acute or symptomatic. Secondary assessment. During your physical exam, remember this should be performed on geriatric trauma patients in the same manner as for any adult, but with consideration of the higher likelihood of damage from trauma. Any head injury can be life-threatening in an older adult. When examining the chest, consider that breathing is normally impaired, and check lung sounds and look to see if there is any evidence of pacemakers or previous cardiac surgery. Decreased muscle size in the abdomen may mask abdominal trauma, and you should look for bruising or any other signs of traumatic injury. Take vital signs. Assess pulse, blood pressure, and skin signs. Remember, capillary refill is unreliable in an elderly person because of compromised circulation. Also, some elderly patients take beta blockers, which will inhibit their heart from becoming tachycardic, as you would expect to see in shock. Repeat your primary assessment. Remember, the geriatric patient has a higher likelihood of decompensating after trauma. Broken bones are common and should be splinted in a manner appropriate to the injury. Effective application of conventional splints and backboards may be difficult or impossible unless a large amount of padding is used. Trying to force a patient with pronounced joint flexion or kyphosis into a normal anatomic position can be painful for the patient and frustrating for you, so we should not force. In hip and pelvic fractures, do not log roll the patient. In general, padding should be done for comfort and to help decrease the likelihood of decubitus ulcers forming. Provide blankets and heat to prevent hypothermia. Communication with the elderly can be challenging, and you should provide psychological support as well as medical treatment. Document your assessment, treatment, and reassessment, including any changes in the patient's status. A medical condition such as fainting, a cardiac rhythm disturbance, or a medication interaction may lead to a fall that injures the patient. Whenever you assess a geriatric patient who has fallen, it is important to find out why the fall occurred. Consider that the fall may have been caused by a medical condition. Look carefully for clues from the patient and bystanders and the environment. Consider that if a medical condition caused the fall, it may be life-threatening. As a result of bone loss from osteoporosis, older patients of both sexes are prone to fractures, especially of the hip. Hip fractures are much more common among women, and contributing factors include stress of ordinary activity, a standing fall, vitamin D and calcium deficiencies, metabolic bone diseases, and tumors. Injuries to the hip also tend to be reoccurring. Elderly patients with osteoporosis are also at risk for pelvic fractures. Recovering from these kinds of injuries can be complicated for the elderly. With age, the spine stiffens as a result of shrinkage of disc spaces and vertebrae become brittle. Compression fractures of the spine are more likely to occur. Here you see using a vacuum to package the patient, which is more comfortable than a backboard, and it does provide spinal protection. You can also see that there's padding under the head to not force the patient into an uncomfortable position. Because brain tissue shrinks with age, older patients are more likely to sustain closed head injuries such as subdural hematomas. Acute subdural hematomas are among the deadliest of all head injuries. Tiny veins between the surface of the brain and its outer covering stretch and tear, allowing blood to collect. Blood fills the skull very rapidly, compressing brain tissue, which often results in brain injury. Serious head injuries are often missed in elderly patients because the mechanism may seem relatively minor. Other factors that predispose an elderly patient to a serious head injury include long-term abuse of alcohol, recurrent falls or repeated head injury, and anticoagulant medication. Environmental injuries. Internal temperature regulation is slowed in elderly people and gets slower with increasing age. The body's ability to recognize fluctuations in temperature becomes delayed owing to a slowed endocrine system. Heat gain or loss in response to environmental changes is delayed by slowed circulation and decreased sweat production in the skin. Thermoregulation can be adversely affected by chronic disease, medication use, and alcohol use. About half of all deaths from hypothermia occur in elderly people, and most indoor hypothermia deaths involve geriatric patients. Living where harsh winters occur is a risk factor, and it can also develop at temperatures above freezing when an older person is exposed for a prolonged period. The death rates from hyperthermia are more than doubled in elderly people compared with younger ones, and Arizona has more heat-related deaths than all other states combined. Response to nursing and skilled care facilities. Elderly patients who you will see, assess, and transfer are often found in convalescent homes, nursing homes, and other skilled care facilities. The kind of facility will depend on the type of care the patient needs. Nursing homes are facilities that serve patients who need 24-hour care and are sometimes a step down from an acute care hospital. Patients require assistance with daily living and need therapeutic or rehab services. Calls to these types of facilities can sometimes be challenging because the staff is usually spread thin, and as soon as possible you need to establish what the baseline status of the patient is. Talk to the staff who directly cares for the patient on a daily basis. With potentially limited information, you need to do an assessment to determine if the patient's problem is life-threatening or requires an ALS level of care. Infection control needs to be a high priority for EMTs when visiting these facilities. Good hand washing and standard precautions can inhibit the spread of infectious pathogens to people who already have a compromised immune system. An infection in an older patient can lead to life-threatening sepsis. There are many risks to the patients and to EMTs. Methicillin-resistant Staphylococcus aureus, or MRSA, infections are common among people who are living in close quarters, such as nursing homes. The organism can be found in decubitus ulcers, on feeding tubes, and on indwelling urinary catheters. It can cause mild infection on the skin or invade the bloodstream, lungs, or the urinary tract. It's primarily spread by broken skin-to-skin contact, but is also acquired by touching objects that have the bacteria on them. Many infections in hospitals are caused by vancomycin-resistant enterococci. Enterococci are bacteria that are normally present in human intestines and female genital tracts. Some of the enterococci have become resistant to the antibiotic commonly used to treat these infections, which is called vancomycin. RSV can cause an infection of the upper and lower respiratory tract. The symptoms are similar to the common cold, but can be more severe and last longer. The virus is highly contagious and is found in discharges from the nose and throat of an infected patient. It is also transmitted by direct contact with droplets from coughs or sneezes or by touching a contaminated surface. MRSA and RSV infections can be life-threatening, especially in a patient who is immunocompromised. You should wear appropriate PPE and decontaminate your ambulance and diagnostic equipment. Document the infection control issue and advise the receiving facility of infectious disease in the patient. Report an infectious disease to your company or the local health department. C. diff, or Clostridium difficile, is a bacterium responsible for the most common cause of hospital-acquired infectious diarrhea. It is a bacterium that normally grows in the intestines, and healthcare workers may carry this bacterium and fall in contact with contaminated feces. It can also be found on environmental surfaces such as furniture, floors, toilets, sinks, and bedding. Symptoms can range from minor diarrhea to a life-threatening inflammation of the colon. You should also be cognizant of potential airborne pathogens. Something as simple as a cold or flu virus could result in a life-threatening pneumonia for a compromised older adult. Dying patients. As elderly patients are living longer, more terminally ill patients are choosing to die at home rather than in a hospital. Often the patient comes to terms with his or her impending death before the family does. Dying patients receive what is called palliative or comfort care. Palliative care recognizes that death, as part of life, is normal. It neither hastens nor prolongs deaths, and it includes relief of pain and psychological care. Your interaction with a dying patient will have a long-term effect on the family. You need to be understanding, sensitive, and compassionate. This is critical. Determine if the family wishes for the patient to go to the hospital or stay in the home. Advanced directives. Advance directives are specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to patients who cannot speak for themselves. If you remember from the medical legal chapter, there was a special segment we talked about the Montana Post form and advance directive. Mentally competent adults and emancipated minors have the right to consent to or to decline treatment provided they are competent to do so. A competent adult is someone who is 18 or older, is alert, is not intoxicated, and understands the consequences of their decision. Patients who are unconscious or in medical crisis are not able to inform medical personnel about their wishes to consent or to decline treatment. Advance directives may take the form of a DNR or do not resuscitate order. This gives you permission not to attempt resuscitation for a patient in cardiac arrest. For a DNR order to be valid, the form must be signed by the patient or legal surrogate and by one or more physicians. DNR does not mean do not treat. If the patient is still alive, you are obligated to perform supportive measures that may include oxygen delivery, pain relief, and comfort. Basic airway breathing and circulatory support should be provided, and cardiopulmonary resuscitation may not be provided. A healthcare power of attorney is an advance directive that is exercised by a person who has been authorized by the patient to make medical decisions for him or her. This is an example of Maryland's Emergency Services DNR order. Dealing with advance directives has become more common for EMS providers because more people are electing to use hospice services and spend their final days at home. When transporting patients from nursing facilities, consider the following general guidelines. Patients have the right to refuse treatment, including resuscitative efforts, provided that they are able to communicate their wishes. A DNR order is valid in a healthcare facility only if it is in the form of a written order by a physician. You should periodically review state and local protocols and legislation regarding advance directives, and when you are in doubt or there are no written orders, you should try to resuscitate the patient. Elder abuse and neglect. Elder abuse is defined as any action on the part of an older person's family member, caregiver, or other associated person that takes advantage of the older person's person, property, or emotional state. It's also called granny beating and parent battering. The exact extent of elder abuse is not known for several reasons, including the following. Elder abuse is a problem that has been largely hidden from society. The definitions of abuse and neglect among the geriatric population vary, and victims are often hesitant to report the problem to law enforcement agencies or human and social welfare personnel. The physical and emotional signs of abuse, such as rape, spouse beating, and nutritional deprivation, are often overlooked and are not accurately identified. Older women in particular are not likely to report incidents of sexual assault to law enforcement agencies. Patients who have sensory deficits, dementia, or other forms of altered mental status may not be able to report abuse. Elder abuse occurs most often in women older than 75. The abused person is often frail, with multiple chronic medical conditions and dementia. The person may have an impaired sleep cycle and periodically shout at others. The person may also be incontinent and in general dependent on others for ADLs, or activities of daily living. Abusers of older people are most often products of child abuse themselves, and the abuse that is inflicted on the older person may not be retaliatory. Most of these abusers are not trained in the particular care that older people require and have little relief time. Their lives are now complicated by the constant demanding needs of the older person they have to care for. The abuser may also have marked fatigue, be unemployed, with financial difficulties, and abuse one or more substances. Environments such as nursing, convalescent, and continuing care centers are also sites where older people sustain physical, psychological, financial, or pharmacologic harm. To assess for elder abuse, you should try to obtain an explanation of what occurred. You should suspect abuse when answers to questions about what caused the injury are concealed or avoided. You should also suspect abuse when you are given unbelievable answers. Information that may be important in assessing possible abuse includes repeated visits to the emergency department or clinic, a history of being accident-prone, soft tissue injuries, unbelievable or vague explanations of injuries, and psychosomatic complaints. Chronic pain without medical explanation, self-destructive behavior, eating and sleeping disorders, depression or lack of energy, and substance or sexual abuse history. Many patients who are abused are so afraid of retribution that they will make false statements. Repeated abuse can lead to a high risk of death. A preventative measure in reducing additional maltreatment of the patient is identification of the abuse by emergency medical providers. Table 33.5 gives you a brief synopsis of the categories of elder abuse, both physical, psychological, and financial. Signs of physical abuse. Inflicted bruises are usually found on the buttocks and low back, genitals, and inner thighs, the cheeks or earlobes, the neck, the upper lip, and inside the mouth. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites are typically inflicted on the upper extremities and can cause lacerations and infection. You should inspect the patient's ears for indications of twisting, pulling, or pinching, and evidence of frequent blows to the outer ears. Investigate multiple bruises in various states of healing. Typical abuse from burns is caused by contact with cigarettes, matches, heated metal, forced immersion in hot liquids, chemicals, and electrical power sources. Observe the patient's weight and try to determine whether he or she appears undernourished or has been unable to gain weight in the current environment. Check for signs of neglect, such as evidence of a lack of hygiene, poor dental hygiene, poor temperature regulation, and a lack of reasonable amenities in the home. Regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. Geriatric patients with altered mental status may never be able to report sexual abuse. Many women do not report cases of sexual abuse because of shame or the pressure to forget. In summary, although assessment of geriatric patients involves the same basic approach as that for any other patient, you must take a more wary approach. Assessment of an elderly person can be challenging because of communication issues, hearing and vision deficits, alteration in consciousness, complicated medical history, and the effects of multiple medications. To obtain an accurate history for a geriatric patient, patience and good communication skills are essential. A slow, deliberate approach to the patient history with one EMT asking the questions is generally the best strategy. With changes in the respiratory system, such as a decreased ability to cough, geriatric patients are more likely to present with pneumonia. Changes in the cardiovascular system can lead to atherosclerosis, aneurysm, stiffening heart valves, orthostatic hypotension, venous stasis, deep venous thrombosis, heart attack, heart failure, and stroke. Many patients do not present with the classic symptom of chest pain when experiencing a heart attack. Atypical presentations are seen mostly in women, elderly patients, and patients with diabetes. Dementia and delirium must be carefully evaluated in the geriatric population. As the body ages, the bones become more fragile. This leads to a higher risk of fracture in geriatric patients. Polypharmacy and changes in medications can cause serious problems for geriatric people. Depression is treatable with medication and therapy, but it is a risk factor for suicide if it remains untreated. The risk of serious injury or death is more common in elderly patients who experience a traumatic injury. When you treat a geriatric trauma patient, assess the injuries and carefully look for the cause of the injury. A medical condition such as fainting could actually cause the fall. The injuries from the fall and the medical condition will need to be addressed. When responding to nursing and skilled care facilities, you should determine the patient's chief complaint on that day and what initial problem caused the patient to be admitted to the facility. Thanks for your attention, and as always, bring questions or concerns to your instructor.